My name is Gitanjali Bansal from NIH Office of AIDS Research, and welcome to this panel discussion. With my colleagues and co-leads for this session, Dr. David Chang of Office of AIDS Research and Ms. Ann Namkung of National Institute of Aging, and both of whom are virtual, you can see on the screen. And on behalf of the planning group, it is my pleasure to welcome you all, including our virtual attendees, to this NIH-sponsored NMAC co-hosted panel discussion, Current Landscape and Future Opportunities for Federal HIV and Aging Efforts. We have a full agenda ahead, so we will move quickly. As we have some virtual panelists and attendees, we will be flipping back and forth between in-person and virtual. So I would now like to welcome Dr. Bill Kapogiannis, Acting Associate Director for AIDS Research and Acting Director, Office of AIDS Research at NIH, and Dr. Richard Hodes, Director of National Institute on Aging, to give the welcome remarks. Dr. Kapogiannis.
Thank you, Dr. Bansal. Good afternoon, everyone. We're delighted to have you here joining us today for this panel discussion to explore how federal agencies, the HIV community, researchers, and clinicians can work together to support people aging with HIV. Thanks to the successful research in HIV, people with HIV are living longer than ever. The most recent CDC surveillance data estimated that half the people with HIV in the US are 50 years or older. In addition, 16% of new HIV diagnoses were in this age group in 2021. People aging with HIV have a higher risk of several comorbidities, face unique challenges, and have complex care needs. This has created a critical need to advance research at the intersection of HIV and aging. Recognizing these unique challenges, HIV and aging is a key focus in the three roadmaps guiding the US government's HIV agenda, and those being the National HIV/AIDS Strategy, or NHAS, the Ending the HIV Epidemic in the US, or the EHE initiative, and the current NIH Strategic Plan for HIV and HIV-related research. The NIH HIV research program has a robust HIV and aging portfolio covering a broad range of topics. Investment in this area has increased in the past several years by 11% since 2019, with $119 million in funding at 17 institutes, centers, and offices at the NIH in fiscal year 2022. This includes more than doubling the investment in NIA's HIV and aging research portfolio since 2018. In 2022, the NIH Office of AIDS Research, or OAR as we are known, which coordinates the NIH HIV research program, launched the HIV and Aging Signature Program to catalyze interdisciplinary research and training focused on HIV and aging. In addition, an NIH-wide working group, co-led by colleagues at OAR and the National Institute on Aging, is facilitating collaborations in research and training and identifying research gaps and opportunities. Importantly, this working group aims to link NIH, people aging with HIV, advocates, researchers, and U.S. government agencies. Engagement with community groups, researchers and providers, and our federal agency partners around this table is crucial to ensure that we respond to the emerging needs and leverage the appropriate expertise on each agency. The collaboration is essential to expedite research findings, promote rapid implementation research of results, and ultimately improve the lives of people aging with HIV. I look forward to today's panel discussion and to our continued shared efforts to advance this critical work. I'm pleased to pass this microphone to Dr. Richard Hodes, the Director of National Institutes of Aging.
I think he's having technical difficulties. We are waiting for him to join. So while we are doing that, I think we can start with panel introductions here. I would now like to welcome our speakers and panelists, and we'll start by having everyone introduce themselves briefly. I think we can just pass the mic around.
I go first. Good afternoon, everyone. I'm Harold Phillips. I'm the Director of the White House Office of National AIDS Policy.
Hello, everyone. My name is Kristen Roja, and I am a Public Health Advisor with the Substance Abuse and Mental Health Services Administration.
Good afternoon, everyone. I'm Dr. Robin Neblett-Fanfare. I'm Acting Director at the Division of HIV Prevention at CDC.
Hello, I'm Jeff Crawley. I'm the Director of the Infectious Diseases Initiative at the O'Neill Institute for National and Global Health Law at Georgetown Law.
Hi, everybody. I'm Igo Ofodokun. I am a professor of infectious diseases at Emory University School of Medicine, a translational researcher that runs a translational lab looking at some of the reason why people develop age-related comorbidities with HIV.
Good afternoon. My name is Michael Carfen. I'm the Director of the Division of Policy and Data in the Health Resources and Services Administration HIV/AIDS Bureau, which administers the Ryan White HIV/AIDS program.
Good afternoon, everyone. My name is Ronald Johnson. I am an older adult living with HIV. I'm retired, but I also serve as a consultant to AIDS United and the Association for Nurses and AIDS Care on HIV and aging issues. And I also serve as the chair of the U.S. People Living with HIV Caucus.
Thank you. Good afternoon. My name is Captain Mary Glenshaw. I'm the lead of the science team at the NIH Office of AIDS Research.
Hello, everybody. My name is Moises Agosto, and I'm the Director of Treatment for IRMAC. I also lead the programs and the advocacy efforts on aging and HIV with IRMAC.
Thank you, Geeta. As Geeta mentioned earlier, this is a hybrid meeting with panelists and attendees joining in person and virtually. So we'll be going back and forth between these spaces. I'd like to welcome our speakers and panelists from online. I'll start by introducing myself, and as I call your name, please unmute and introduce yourself. My name is David Chang. I'm a senior science advisor in the NIH Office of AIDS Research. I'll go to my NIH colleagues, Ms. Ann Namkang.
Ann Namkang. I'm at the National Institute on Aging, and I'm the program director on HIV and aging research.
Thank you. Dr. Melissa Gerald.
Hello, everyone. I'm Melissa Gerald, and I have the pleasure of working with Dan in the National Institute on Aging, and I'm a program officer in the Division of Behavioral and Social Research.
Thank you. Dr. Basil El-Dada.
Hi, Basil El-Dada. I too am at the NIA. I'm a program officer in the geriatrics branch in the Division of Geriatrics and Clinical Gerontology.
Thank you. Dr. Yolanda Oladende.
Good afternoon. My name is Yewande Oladende, and I am a program officer in the Division of Clinical and Health Services Research at National Institute on Minority Health and Health Disparities. Is my camera on? Do you see me?
No.
No, not at the moment.
All right, I'll fix it. Sorry about that.
Okay, Mr. Jules Levin.
Hi, everybody. This is Jules Levin, the Executive Director and founder of NATAP, the National AIDS Treatment Advocacy Project. Many of you know me. I've been working on aging and HIV for 17 years. I've had HIV for over 40 years, and I'm 73 years old and suffering with multiple comorbidities myself. Dealing with it is very difficult. And thank you all for being here today. And thank you to the NIH leadership and OAR team and OAR leadership and everybody here participating in this event. Thank you for organizing this.
Thank you, Jules. Dr. Eugenia Siegler.
I'm Jeannie Siegler. I'm a geriatrician at Weill Cornell Medicine, and I have a special interest in aging with HIV.
Thank you. Dr. Michelle Schreiber.
Hi, I'm Dr. Michelle Schreiber. I'm the Deputy Director of the Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services, or CMS. The CCSQ is its clinical arm. Delighted to be here today. I also want to mention that in my earlier career, I was an HIV provider as a primary care physician in the city of Detroit.
All right, thank you. I think that's all from the virtual side. We'll back to you, Geeta.
Okay, thank you, David. Is Dr. Hodis online now or no? Okay, so I think we can move ahead and then come back. We indeed have a panel rich with experience and complementary expertise, so thank you all for being here. I will quickly give a brief overview of session objectives and this session. As you heard from Dr. Kapochianis about the launch of the signature program on HIV and aging last year to build on NIH's HIV and aging research, and earlier this year, a multi-ICO HIV and aging working group co-led with NIA. This working group organized a research workshop earlier this week, and today's panel discussion co-hosted by NMAC is a follow-up to that workshop. So the research workshop and this session are developed around 4 pillars as shown on the screen. Slide. Thank you. These are interdisciplinary research, integrated models of care, implementation research, and interagency efforts. So the objectives for this panel discussion are to identify and leverage integrative collaborations and facilitate discussions among federal agencies, members of the HIV, as well as research community and healthcare providers to prioritize interdisciplinary research and implementation strategies that address the need of people aging with HIV. Reflecting this multi-sectoral approach, the planning group also included members of the HIV and research community, CDC, HRSA, and volunteers from different NIH ICs of the working group. A huge thanks for their partnership and collaboration in planning of these events. So today we'll have remarks from White House Office of National AIDS Policy Director, Mr. Harold Phillips. I will then give a brief summary of the September 5th research workshop. We will hear about communities' perspectives from Mr. Jules Levin, Ms. Linda Scruggs, and Mr. Moises Augusto Rosario. And then we'll have the panel discussion followed by the moderated live Q&A and final thoughts from Dr. Tim Holtz, Deputy Director, NIH Office of AIDS Research. So over to you, Mr. Phillips.
Thank you very much. Good afternoon, everyone. So once again, I'm Harold Phillips. I serve as the director for the White House Office of National AIDS Policy. I am, in case you didn't know, I'm a gay black man living with HIV. You may not know, but you might from the white hair. I am 57 years old. I have been living with HIV for 18 years, and I've been on antiretroviral therapy for about 17 years. So as we talk about sort of representation and meaningful representation of people living with HIV and those of us within the federal government, for some of us, this is not only sort of an issue of professional importance and of importance to the nation, but also to us as individuals. And everything that goes along with that, sort of managing my own care, managing the care of my mother, who I will not tell you her age, because that would be rude. But as she ages, figuring out her stuff, my stuff, I'm starting to keep a calendar of her medical appointments as well as my medical appointments, and she doesn't even live with me. So all of those things and the above are part of why some of this is of interest, but also I'm going to give you a little bit of sort of the national context and a little bit too of a flavor of what some of our federal partners are doing. And this is not a comprehensive list. And hopefully as I go through this and also the panel shares their pieces, you'll begin to understand that the federal agencies and partners all get it, that this has arrived. I think what Jules talked about, he's been in this work for 17 years and has been saying this is going to happen. It's here, it's happening, and everyone is responding to it. I'm grateful to have this opportunity to be with you all today, and we're having this discussion. And we are also having this discussion many times over as federal partners when we get together as well. But it's great to have an opportunity to be able to share some of this with you all and to also hear from you too. Especially thank the collaborating institutes, the centers and the offices at NIH, and the community partners for making this event happening. happen. HIV and aging is a significant topic for discussion, both domestically and globally. And I want to also encourage us to try and learn, too, from our global partners who are also facing these issues. When we discuss HIV and aging, we are including people diagnosed with HIV at a later age, as well as the long-term HIV survivors. Aging can be difficult for the general population. One of our federal partners that I will not call out by name has said several times that aging sucks, and it does. And there are no exceptions when it comes to the similar and unique ways that people with HIV experience aging. Many of you may have heard the statistic that over 50% of the people with diagnosed HIV in the United States are over 50 years of age. Like other age groups impacted by HIV, older people with HIV experience barriers to receiving care, staying in care, and obtaining viral suppression. And the most recent CDC data shows that for people with HIV over the age of 55, about 75% received care, only about 60% were retained in care, and that approximately 67% were virally suppressed. This illustrates that there are many older people with HIV who are not being reached, and there are unique challenges that are present for HIV prevention among this population as well that we need to also consider. Related to these stats that I just mentioned, older people with or at risk of HIV face several challenges. Some of these we know, and they are no surprise. Although they visit their doctors more frequently, older people and their providers are less likely to discuss sex or drug use behaviors. Healthcare providers may not ask patients over 50 or older about these issues or test them for HIV. Also, older people may not consider themselves to be at risk for HIV, may be embarrassed to discuss sex, or may mistake HIV symptoms for those of normal aging. Older people in the United States are more likely than younger people to have late-stage HIV infection at the time of diagnosis. I think at this conference we've heard loud and clearly about that, especially when it comes to Black women and being diagnosed later with late-stage HIV. People aged 50 and older may start treatment late, which may put this population at greater risk of more immune system damage. We also know that stigma is a common factor among adults with HIV and negatively affects people's quality of life, self-image, and behaviors. People aged 50 and older may avoid getting the care they need or disclosing their HIV status because they may already face isolation due to illness or loss of family, friends, or community support. Comorbidities and co-infections and complications of aging with HIV present special challenges for preventing other diseases. Both age and HIV increase the risk for cardiovascular disease, bone loss, neurocognitive decline, and certain cancers. People aged 50 and older also need to be careful about the interactions between medications used to treat HIV and those used to treat common age-related conditions such as hypertension, diabetes, elevated cholesterol, and obesity. Acknowledging these challenges and others, the current National HIV/AIDS strategy, released by President Biden on World AIDS Day of 2021, includes goals to address HIV among older Americans and other segments of the population affected by this condition. Within the strategy, Objective 2.5 seeks to expand the capacity to provide whole person care to older adults with HIV and long-term survivors. This includes identifying, implementing, and evaluating models of care that address aging-related issues, identifying and implementing best practices to address behavioral health and psychosocial needs, increasing capabilities of providers of social services used by older adults, such as senior services, housing services, and disability services to support older people with HIV. Promoting research into aging-related conditions in people with HIV of all ages, and encouraging multi-agency, multi-sector collaborations to support the ability to age with HIV. We've also included new quality of life indicators as part of the strategy as well, which include self-reported health status, mental health, food insecurity, unemployment, and unstable or homelessness, recognizing that you may be unstably housed before you actually reach homelessness. So you may be worried or not have a stable place to live before you actually get to that stage. The data sources for these indicators include the CDC's Medical Monitoring Project, and we will be producing a progress update that outlines sort of our progress in achieving those quality of life indicators. Quality of life indicators were developed as a result of conversations with the community that really talked about people living with HIV are more than just their lab values, the CD4, the viral load suppression, really thinking about quality of life and how do I live with HIV. So the indicators give us an opportunity to think about that and think about what are the collaborations and partnerships we need, because with the quality of life indicators, our HHS partners can't do it all. So think about that. Also, and I think when it comes to aging, it also allows us to bring in new, different, and unique partnerships, such as our partnership with the Administration for Community Living, which has been strengthened and enhanced by this work and by the strategy and their work as part of the Federal Implementation Group. This panel discussion today is another action that will play an integral role in meeting our national goals related to HIV and aging. The attendees present here today represent the research, community, service, and other sectors, and your attendance today represents your commitment to improving the lives of older adults with HIV. I commend you all for your presence here today, and I make a call to action for you to keep at effective collaborations in this area, and I look forward to hearing the information that will be relayed during the panel today. Thank you.
Thank you, Mr. Phillips. So the next, I will go over the summary from the workshop. So this workshop and today's session, as I mentioned, are developed around 4 pillars. That is considering the intersectionality of stigmas, HIV infection, aging, and related comorbidities in biological and socio-behavioral contexts. Interdisciplinary research is needed. There's urgent need for integrated models of care and related implementation research. And with different US government agencies having different roles, interagency efforts play a crucial role in addressing the needs of older people with HIV. So the objectives of the Tuesday's workshop were to survey the current landscape of HIV and aging research and identify key future research directions to address these needs of people aging with HIV. We started the workshop with community perspectives and keynote talks to set the stage for the following 3 sessions. You see on the screen, these sessions were on co-occurrence of HIV geriatric syndromes and comorbidities, as well as understanding mechanisms that drive decline in function, and also barriers to translating research evidence to clinical care. So we heard about data on different comorbidities from different cohorts, the Women's cohort, Charter, MaxWise, among others. We also heard about some mechanistic studies looking at comorbidities from the lens of immunity, translational studies using imaging, for example, to study neural activity related to cognitive function differences. And so for the sake of time, I won't be able to go through everything, but people aging with HIV, over half of the people are diagnosed are 50 and older, and they are aging. The median age of population living with HIV has been gradually moving upwards over the course of the last 20 years or so. And what we heard was that people with HIV have higher risk of and experience comorbidities more often, whether it's cardiovascular disease, liver disease, lung disease, for example, COPD, some cancers, diabetes, cognitive decline. And then people with HIV experience certain comorbidities earlier than people without HIV. For example, men with HIV experience frailty at a younger age compared to men without HIV across different age groups. People with HIV over 50 had an added risk due to substance use disorder. Impact of both HIV and antiretroviral therapy, sometimes on adipose tissue, and how that might have a role in cardiovascular disease and plaque deposition. Data indicating weight gain as an important issue related to the treatment of people living with HIV. We also heard older and elderly people with HIV face disparities and experience stigmas. Some of these issues that people aging with HIV face are similar to people without HIV. However, people with HIV have more serious consequences. Health system issues similar, system issues can be similar, but consequences can be greater for people with HIV. Disruptions in art, for example, during transition to long-term care. Greater risk of drug-drug interactions if communication is not good between different providers. So these are some of the unique challenges that people with HIV face. So aging with HIV is multifaceted and complex. We also heard quality of life, and as Mr. Phillips alluded to, and functionality significantly drops with age with each significant life event as it occurs. And the goal should be to move this curve that you see and bend the curve upwards to improve the quality of life. I also saw some data showing improved physical function with senolytics in mice, and ACTG is working on expanding this to humans. We also heard that it's critical to understand how sociocultural factors can impact health. It's important to incorporate these factors to better understand brain-behavior relationships, reduce the risk of misdiagnosis using consensus-driven hand criteria, and utilize evidence-based approaches to remove barriers and enhance care. We also heard what are the hurdles in implementing research into actual practice. We started with community concerns about aging. As Jules said, older elderly people with HIV have greater care needs not being met. They face premature frailty, falls, fractures, bone disease, etc. There's underutilization of prevention and screening strategies, and there's urgent need for integrated care to address these medical issues. People aging with HIV also experience discrimination and stigma, not like younger people with HIV. And as Moises, you presented, there's significant difference in number of deaths of persons diagnosed with HIV age 55 and older by race. And there's structural racism and discrimination of aging and health. This was particularly highlighted for MSM and an important issue for Black women, as presented by Linda. How do aging and comorbidities impact various groups differently? We need to address in biomedical and socio-behavioral research, as well as development and delivery of care. As one of our keynote speakers, Dr. Amy Justice, showed, living longer isn't enough. We need people to live better. We need a personalized approach to address the complex issues of aging with HIV. And as Dr. Siegler, one of other keynote speakers, said, if we are going to address these many complex factors at the intersection of HIV and aging, we need basic and translational research and also behavioral and implementation science. Dr. Siegler pointed out, while the clinic has historically been the center of care, we need to think beyond traditional clinic models about innovative ways to deliver care, to ensure that effective interventions are being translated into practice, allowing for integrated care that addresses not only HIV, but issues of aging and comorbidity as well. We also got to hear from one of our speakers about integrated care models, their experience at 2 different clinics with 2 different implementation strategies, and also learning from outside the field, for example, models for aging with cancer and LMICs, learning from them about adaptability. We also heard about the need for more geriatricians and trained workforce. So to summarize, over half of people with HIV are over age 50. Elderly people with HIV face disparities and experience stigma. People with HIV experience comorbidities earlier and more often. Significant research is being done focused on aging with HIV, and more is needed to understand mechanisms of aging with HIV, interventions to address HIV and comorbidities, to have integrated care models that break down silos, and have a trained healthcare workforce. And of course, research resources are needed to do so. And as you see in this graph, aging with HIV is different from normal aging, and we need interventions to move the curve for longer and healthier lifespan. So this was the summary from our research workshop. I will now turn over to Mr. Jules Levin to start with the community perspectives.
Hi, can I see my slides? The 2 slides?
Yes, they should be showing on now. Yes, Jules, they're there.
Next slide. Okay. Thank you, Geeta, and thank you to everybody again for being here today. So my presence and my discussion are for this. Why are we here today? And why are we meeting? Not to be repetitive, but to hear it from me, a person living with HIV for 40 years, knee deep in aging and HIV for 17 years before it was recognized as a problem, and 73 years old myself. Older and elderly people with HIV have much greater care needs, but we're not getting our care needs met in the clinic. And I'm going to indicate exactly what's going on. We're not getting our care needs met in the clinic. At CROI, it was called the Silver Tsunami. Clinical care in the clinic where they're not equipped to give us the care we need today or in the near future, and we're not getting the care need that we need, care needs that we need, they're not being met. There are over 200,000 people now over 60. There's going to be over 400,000 people by 2030 with HIV in the United States. Right now in New York, over 50% of people with HIV are over 60, and in San Francisco too. We're experiencing by as many as 20 years earlier onset of comorbidities like heart disease, heart attacks, kidney disease, mental decline, cognitive impairment, physical dysfunction, unable to perform normal daily activities, and frailty and social isolation and loneliness. And we're not getting any support in the clinic right now. We're experiencing premature fractures and falls. Many people are getting fractures and falls, men and women, and cancers. And chronic kidney disease will become a much bigger problem as we move on. We have no idea at this point in time how many of our folks are on dialysis. And in the clinic right now, there is no screening and no prevention and no geriatric care programs for things like falls prevention, diabetes management for older people, and there are no mental health services to address cognitive and physical decline. Physical therapy is very difficult to get. It's very difficult to get mental health services, and we have no programs for good food and diet and exercise. African Americans, Latinos, and women suffer disproportionately from aging with HIV. We need 2 things. We need better care, screening, prevention, and we need better research for older and elderly people. And the ACTG can play a primary role. Research to this point has not addressed the need to bring into the clinic findings of research studies that improves the actual care in the clinic. Next slide, please. So lastly, I want to tell you what's really going on today in the clinic in New York City and other places, because I speak to people all over the country. We're not getting our clinical care needs met. There is little to no care coordination between the HIV doctor, the primary care physician. The visits with your doctor today are 15 to 20 minutes. They're totally inadequate for a person with multiple comorbidities. There's no time to address and discuss with your doctor all the comorbidities and problems you're having. And they often don't understand what you're talking about and don't take the time because they don't have the time to talk to you about it. And they don't take the time to engage with you about key geriatric health concerns. Patient-doctor communications is completely lacking. They're hamstrung by limited time availability, ruined by very limited reimbursement. Reimbursement is caused all this. You can sometimes wait 3 months to get an appointment with your doctor or a specialist. In New York and many other major hospital clinics, they have what they call a telephone tree. You cannot get in touch with your doctor's office anymore. You call and you go round and round and round and never get through. They don't return your phone calls. And the same thing happens in portals. You can put in a question and a message to your doctor. They never get answered. They get ignored all too often. Referrals often do not happen for bone mineral density testing. It's absent, even though it's recommended for everyone over 50. There's no frailty testing. There's no cognitive function testing. And there are often waiting lists for months to see a specialist. And so the result is elderly people with HIV over 65 are left on their own to cope. And you are unable to measure what's going on to people like me by collecting quality of care MMP, quality of care indicators that in no way can identify what's going on with me and other people like me in the clinic. So we need a model of care that integrates comprehensive inclusion of all our needs, but we don't need it in 5 years. We need it today, because what I'm describing you here today now is what's going on in the clinic today now. And so there's no discussion around collecting data that might help in 10 years from now. We are sick and getting sicker and dying now, and there's no help in the clinic now. Thank you.
Thank you. Thank you, Jules. Moises?
I just briefly want to mention two topics, two issues that I think are very important. I mean, it's great that we're going to be able now to start talking about the research needs and, how we translate knowledge of HIV and aging into implementing it into the community, into programs. So all of that is a continuity. And sometimes, we keep the conversation about research not connected to the conversation about programs. But one important issue for me is health disparities. We find into communities that are coming to aging already with an intense set of obstacles and challenges to access quality care. It is maybe because of the financials, because of living in rural communities, and also in communities of color, we come to this age also with a heavy bag of trauma and situations that we bring because of discrimination, because of a stigma, and we are adding another layer into that, which is that have to do with ageism and aging, and what does that mean when you have to go to a home and you have to go back to the closet because you're afraid to come out into the rest of the people there. So health disparities is critical, and it has to be something that cannot be thought like an end thought. I think that at this moment in which we're thinking about how to integrate biomedical research or behavioral research into or translating into interventions and programs that we integrate, how do we make sure that the health disparities gap does not increase when people come to the system? The other issue that I think is important is social determinants of health. We could develop, great science, we can develop great treatments and intervention, but if we don't address the health disparities, the social determinants of health that a lot of communities face, and the aging community face a lot of them in terms of housing, we face them in terms of like financials and poverty levels. And also we face them like how we have mobility, if we live in big cities or rural community, transportation, food. These are things that need to be part of the same discussion. And that's what I'm thrilled to see that here we have a group of all the different agencies that can address that within the discussion. So those are my issues.
Thank you so much. Linda, please.
Good afternoon, everybody. My name is Linda H. Scruggs. I'm the co-executive director of Ribbon. I'm a Black woman aging with HIV for about 33 years now. I actually stopped counting. Just real quickly, just because many of you don't know, Ribbon is the youngest national nonprofit in the HIV community, and we actually do chronic disease. HIV is our primary area. And I say that because one of our major roles is really organizing and spending time in the aging community. But Ribbon is not a women-only or women-focused organization. Folks keep thinking that because we are two Black women-led women living with HIV, but we are not. But I'm going to talk about Black women very specifically since we're writing Black women a love letter this week, and I'm probably too tired at this point because I feel like I've been everywhere. And for the Black women in the room, please don't attack them. I choose not to be up there because somebody's thinking why I'm not up there. It's okay. Don't advocate for me. But I do want to take for a moment, and I want us to center Black women. When we're having this conversation around new levels, and as we're re-leveraging and redesigning or refreshing how we're going to address aging and HIV, I really want us to do this very intentionally. As Jules said, he's been talking about this for 17 years. I know that Moest is a ditto everything my colleagues have already said, but I really want us not to be the flavor of the month. While we're centering Black women and writing this love letter, I really am expecting, and part of the reason why I took the charge when Jules asked me to come and be part of this was to ensure. Because one thing I know, if you're not at the table, you're on the table. And what I've come to find out as a Black woman for nearly 60 years now, you may not even be on the table. You was left on the stove because you really wasn't good enough to get on the table. Some of y'all had people bring those dishes to your houses. So I'm just saying. But I really want us to make sure that we're centering Black women and all Black women. I'm saying that as a threshold of inclusion intentionally. We have to do that. I really want us to also look at the framework of MIPA a little differently when you're doing this. When we're talking about how are we including Black scientists, Black women scientists in representation and research and at all levels of research and also in NIH. Because I absolutely know when you have Black women with the authority, given the authority to be at the table, not just with their degree and credentials, but with their lived experience. So she don't have to be a Black woman living with HIV to happen to be a researcher. We do know some of those, but also having the authority of the Black women who are in these leadership spaces. Many of us saw this week, everybody brought their Black woman who worked with them to the conference to stand up. But do those Black women have the authority to really influence the change that's needed in this intentional space? I really want all our federal partners to think about that, as well as looking at the funding mechanisms that really create leverage space for Black women, Black-led organizations that center Black women in this space. Black women have been here since the beginning of the epidemic. Black women have been the mothers of the epidemic, but we really have been left in the kitchen quite often. I really want us to optimize the opportunity as we're refreshing the framework, as we're doing some new work, to really create a recipe that we are included with full intention and inclusion like everyone else. We are a large number of that 210 that are represented right now in the aging population. We can no longer be in a place where we're complacent with the minimum amount of individuals of women, more or less Black women, the minimal numbers into our research and our clinical trials. They have to be created, they have to be publicized and marketed and available in clinics, and clinic staff have to be trained on how to include and what is uniquely needed differently for Black women to be part of it, different from a white older MSM. It's going to be very different. It's not hard. It's about the will that we're willing to do something just a little bit different. Thank you.
Thank you. Thank you so much for sharing that. Um, Over to you, David, for virtual panelists.
Great, thank you. So we've convened this panel together today to bring together different federal partners to address HIV and aging and the different efforts that different federal agencies are making to serve people aging with HIV. As a little bit of an orientation, we'd like to go around to our federal partners and briefly share about 1 to 2 minutes of their ongoing HIV and aging activities, highlighting any interagency community collaborations, and just to the audience, the attendees, a chance to hear what each agency is doing in the space so we can start the discussion. With me moderating today, I'll also announce, is Mr. Levin, Jules Levin. We'll be starting in the moderated discussion part. But first, let me ask our virtual panelists from federal agencies. Dr. Michelle Schreiber, would you like to take a minute or two to briefly describe ongoing HIV and aging activities, highlighting any interagency or community collaborations?
Sure, thank you, David. First, I have to recognize this moment in history that we're talking about HIV and aging and that people are now transitioning into Medicare. This is relatively new, and we recognize that there are challenges, and the agency is very committed to trying to overcome some of these challenges. This is a sometimes difficult transition. People have been used to their commercial insurers, have been used to Medicare, Medicaid, have been used to, Ryan White funds, and recognize that sometimes there are challenges in coverage decisions and care coordination, and even sometimes having to change providers. And so CMS is really very committed as an agency to moving forward in patient-centered care, in patient-focused care, and in integrated care, and certainly integrated care models. I do want to share with the audience a few things that are actually in rule writing as we speak. So if you're interested, the comment period closes shortly, but there's still opportunity to provide comment, because this year in the PFS, which is the clinician and ambulatory rules, there are a number of things that we think are actually very important. There's some coding and payment changes actually that are very specific to better account for providing patient-centered care, including multidisciplinary care, team-based care. There's the ability, at least in the proposal, to pay separately for community health integration, for performing risk assessments for social needs, for social drivers of health, and for covering what's called the PIN, the Principal Illness Navigator. And the Principal Illness Navigator is meant to be a person who is coordinating with the clinician. It can be a community worker, or it can be somebody else who is working directly with the clinician, who can provide care coordination and care support, referral to community services, and help coordinate overall care. You'll see also in the PFS rule for dental care, there is a proposal to cover dental care for transplant. And there's also a question specifically in there, looking for comment on other disease states or chronic illnesses where dental and oral services may be essential, and this is the key wording, essential for the success of the medical services. Now, I think HIV actually relates to that and is a possibility, so commenting on that would be important. In terms of Medicare Advantage, Medicare MA and Part D, they've added HIV to the list of conditions that would make a person eligible for medication therapy management, which I think is also extremely important given the complexity of the medications that are frequently used and the drug-to-drug interactions that can occur, as we've already heard and know about. In addition, there's a proposal for increased payments for homelessness, recognizing that that's a community that really needs additional assistance. So there are things that CMS is trying to do. We recognize Medicaid for a long time has been very used to and welcoming of the HIV population, pays for things like long-term care, for example, which isn't a covered benefit in Medicare at the moment. But that the transition is something that we need to support, and we look forward to partnering with our federal partners and with the community and all of you as stakeholders so that we can ease this and really make this a better transition. I will say, even as part of this committee, we have been working in a more integrated fashion with both across our agency, so Medicare, Medicaid, the marketplace, and our models, as well as across the federal space with AHRQ, with NIH, with the CDC, and with HRSA, and look forward to continuing our partnership with all of you. So thank you for the opportunity to be here today. Thank you, David.
Thank you, Michelle. I'll now ask Melissa Gerald from NIA to present 1 to 2 minutes about your agency's efforts in HIV and aging.
First of all, I want to convey the regrets of our director, Dr. Richard Hodis, who has been experiencing technical challenges and is unable to meet. He does convey his regrets. But I get it here to be, I can give you a little overview of NIA, and I also have my colleagues here from NIA who can also contribute. So while many institutes and centers and offices across NIH are supporting research on older adults, NIA's mission is guided by our vision to enable all Americans to enjoy robust health and independence with advancing age. And specifically, our mission is to support and conduct genetic, biological, clinical, behavioral, social, and economic research on aging, to foster the development of research and clinician scientists in aging, and to provide research resources, and to disseminate information about aging and advances in research to the public, healthcare professionals, and scientific community, among other audiences. And so we're currently supporting research grants, training grants, and career development and fellowship grants that are focused on HIV and aging in each of NIA's 4 divisions. And that's the Division of Aging Biology, Division of Behavioral Social Research, Geriatrics and Clinical Gerontology, and the Division of Neuroscience. And so NIA's research priorities in HIV and aging reflect these subdivision interests. We're interested in understanding the impact of HIV infection and pathogenesis in the context of aging-related genetic, molecular, and cellular changes and physiological outcomes. Also to understand the molecular mechanisms that may be common to multiple comorbid states with HIV, to understand the contributions of individual, interpersonal, social, structural, institutional factors to the physical, psychological, and economic well-being of people with aging with HIV, as well as social inequalities and inequities and health disparities. And also to understand and assess the treatment of older individuals with HIV and comorbidities, polypharmacy, disability, or disparities in health outcomes. NIA's played a co-starring role in the NIH's HIV and Aging Working Group. And while NIA has been participating in a number of different HIV-focused funding announcements across NIH, we've been taking the lead for years now and continuing to take the lead in soliciting research in the multidisciplinary studies of HIV, AIDS, and aging, and also with respect to soliciting administrative supplements for HIV, AIDS, and aging research. And this scope is broadened considerably as we understand more and as we are deepening our understanding. And so that's what I say right now. I'm happy to discuss more of this later. Thank you.
Thank you, Melissa. And back to you, Geeta, in the room.
Thank you. So now we will start with the federal government agencies here. From CDC, Captain Robert Nablet Fanfare.
Hello. Oh, great. Thank you. Good afternoon. Thank you so much for giving me the opportunity to speak today. Improvements in HIV treatment and care have translated to individuals with HIV living longer, healthier lives. As these individuals age, their needs shift, and ensuring this population's unique needs are met is a CDC priority and instrumental to ending the HIV epidemic. CDC's focus is putting science into action, and we are focused on understanding the unique needs of people with HIV as they age. Improving access to care and advancing health equity are priorities for CDC and myself. That is why CDC is working with federal and community partners to address gaps in services for people with HIV across the HIV care continuum, including for people aging with HIV. For example, CDC engages with partners and community members to seek input from diverse community members, including people with HIV aged 50 and up, and we continue to hear from the community, which allows us to improve our engagement efforts. CDC has several projects and partnerships ongoing or planned to research the needs of people aging with HIV. For example, CDC conducts the HOP study, which is a longitudinal study of adults with HIV. And as of June 30th of this year, almost 2/3 of the active participants are over the age of 50. As a science organization, CDC is committed to research on HIV and aging. In recent years, we have published or submitted many publications, specifically looking at care for people over the age of 50. We're looking into studies to help improve the quality of life of people with HIV age 50 and over. And we're also looking to analyze multiple data sources to better understand comorbidities and health outcomes among long-term survivors. Finally, CDC's Atlas provides data using 10-year age groups. Next year, Atlas is planning to present data on HIV diagnoses, prevalence, and stage 3 classifications in 5-year age groups for people 50 to 85 to provide more detailed data for older populations. And I just wanted to say a special thank you to Jules, to Linda, and to Moises. In addition to my role as acting director at CDC, I've also been a provider for people living with HIV for 15 years. And for the past 7 years at the VA, where more than 90% of the people I have the honor of serving are over the age of 50. So as you about aging with HIV, I think about so many of the veterans I have the opportunity of serving. As you talked about women, Linda, I think of one specifically who've recently been diagnosed with breast cancer, who are dealing with PTSD from sexual trauma, who are dealing with the changes of menopause. As Jules and Moises were speaking, I was thinking of patients that I've had to send to cognition clinic who are dealing with falls and who have had inpatient stays due to the crippling loneliness and isolation brought on by COVID-19. So thank you so much for sharing your stories, and I'm here to answer any questions.
Thank you. Mr. Michael Carfin from HRSA.
Good afternoon again, and thank you for the opportunity to participate with this exceptional panel and also to hear from our community members and their perspectives. HRSA administers the Ryan White HIV/AIDS program, which serves about half of all the people diagnosed with HIV in the United States, and as has been cited, and other statistics this afternoon, about half of those recipients of services are also over 50 years old. So this has become a growing concern and a growing direction for the Ryan White HIV/AIDS program. And we are very much tracking some of the domains that have been mentioned this afternoon in terms of the approaches of the interagency work. We collaborate with multiple federal partners NIH, Administration for Community Living, as was mentioned, HUD, and other federal agencies, in particular along the lines of people who are aging with HIV. We also provide technical support to our recipients in terms of their opportunities to both in the clinical level and in the system level in terms of their approaches toward services for people who are aging with HIV. And that's an important aspect of the Ryan White HIV/AIDS program, that this is a locally driven program. So as we see differences across the country, that the program is very flexible in terms of meeting individuals in their various different community settings. We also are very much attuned to the data that has been referenced as well in terms of our understanding of the dynamics of individuals with HIV who are served by the Ryan White HIV/AIDS program. Harold mentioned earlier in terms of national numbers, the Ryan White HIV/AIDS program has seen about 90% of viral suppression among participants in the program. So we see that there are successes or advances that we've been able to make in the program, and very much that's because of an integrated model of care. There are both clinical care and support services that are aspects of what is a holistic, comprehensive approach to care, which has been the model since it was started 33 years ago. There you go. I remember that. I do want to also make an aspect that we do work very collaboratively with other national partners, those that are stakeholders in the field of HIV, but also in the field of aging as well. And many of the topics that I think we will get to, I hope, in our conversation are ones that are focus of the Ryan White HIV/AIDS program. And on a personal note, as well as Harold and others have mentioned, I am a person with HIV who is aging. I heard earlier about all of the various different medications, most of which, as I mentioned to Ron, I'm also taking. So this is a personal stake as well as it is in terms of the agency's investment. Thank you.
Thank you. Ms. Roja from SAMHSA.
Hello. So yes, my name is Kristen Roja. I'm a infectious disease epidemiologist, and I work for the Substance Abuse and Mental Health Services Administration, or SAMHSA. And for some folks who may be unfamiliar with SAMHSA in the room, I just want to share quickly a little bit about SAMHSA, the agency. Our mission is to lead public health and service delivery efforts that promote mental health, prevent substance misuse, and provide treatments and support to foster recovery while ensuring equitable access and better outcomes. SAMHSA envisions that people with affected by or at risk for mental health and substance use conditions receive care, achieve well-being, and thrive. And I think this is an important opportunity to mention SAMHSA's working definition of recovery, which is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. So SAMHSA is not a research agency. We are an agency that funds people who implement evidence-based practices and cultural practices. However, some of our grant recipients do take the opportunity to conduct research while they implement SAMHSA programs. We do have our largest amount of funding is through our block grants. Our block grants currently do not fund very much in the way of HIV. That is due to a case definition of 10 cases of AIDS per 100,000 of the population, which has not changed. However, we do have 5 flagship programs that focus on the intersection of substance use, mental illness, and HIV. We have programs that integrate HIV and behavioral health care, programs that are focused on prevention of substance use disorder and HIV, and programs that focus on treatment of substance use disorder among people who are vulnerable to or living with HIV. And my notes. as well, SAMHSA is very focused on listening to our community partners as well as our grant recipients. So I want to share a few updates that have happened in the past year since the last USCHA conference in Puerto Rico that is a direct result of listening to our community partners and our grant recipients. The first is the introduction of a new activity for our grant that focuses on the treatment of substance use disorder for people who are vulnerable to or living with HIV. That is to provide trauma-informed, non-judgmental, culturally appropriate substance use disorder treatment for long-term survivors and people aging with HIV with a substance use disorder. The grants that have that incorporated will be beginning on September 30th of this year. So stand by for more information. We'll be watching those grants quite closely to see how they implement. The next is someone had mentioned the lack of clinical care. And so one thing that SAMHSA also focuses on is peers, the importance of peers in a recovery system. And so SAMHSA does fund peer support services that include people living with HIV in the care team. And finally, someone else mentioned dental kits or dental care. And SAMHSA has also recognized the behavioral health care and dental connection. And as a result, we are now funding dental kits. We cannot fund dentists through SAMHSA funds, but we can fund dental kits. But anyway, that's a brief introduction to the work that SAMHSA does in this space. And thank you to everyone, to the community partners who share their priorities. And I look forward to the discussion.
Thank you so much, everyone. So we'll start with the panel discussion now, and we will try to get through as many questions as we can. So the first question is, how can, so we've heard a lot about co-occurrence of HIV, aging, comorbidities, importance of considering mental health, substance use, as well as social determinants of health. These can be very different fields or areas, research or otherwise. So how can crosstalk be facilitated between all these different fields at research level, for example, for clinical and translational research, also particularly integrated models of care, and then considering interagency efforts too. So it's open to all. Whoever wants to go, please. Yeah.
So I am not an expert on this, but I think, something was said earlier, a lot of this is happening in key places, so it's just identifying where this leadership exists. I see Vince from San Francisco, the Golden Compass Initiative. Ronald and Carlton are part of a Maryland Aging Coalition. I mentioned Golden Compass, and they said we have our own model. So I think there's these places out trying to do different things, so sometimes it's like writing them up, telling people what's working or what the common lessons are.
Yeah, that's a great point, learning from each other, each other's experiences. Yeah, thank you. Do you want to go?
Yeah. Well, as Krista mentioned earlier, not every agency has authority to do research, but at HRSA we do have the authority to do implementation science and demonstration projects. And we have launched a new initiative on aging and HIV with sites across the country, which will be evaluating different integrated models of care and interdisciplinary approaches, addressing many of the factors that such assessments, such as frailty, such as isolation, such as many of the issues that have been raised, as well as doing that centered in an equity approach, given the disparities in those who are aging with HIV. So these, to us, is an opportunity to both do this in an actual implementation, but then also to advance the field and advance how do we integrate this into the core programs.
So, Geeta, just to add to that, I think, you mentioned the multidisciplinary nature and some of the gaps. So, they span basic sciences, clinical, translational, behavioral, social sciences, as well as implementation science. So I think, at NIH, each of these areas are prioritized by the institutes. And so I think what we, as you know, in our role as the Office of AIDS Research, we provide the ability to coordinate and foster, provide regular venues to foster collaboration and promote synergies across these various agendas, particularly when there may be overlapping interests, and especially to not impede, but to allow the individual institute to carry on its mission and also synergize within the areas that we're looking to fill. So I think it's really important, and because we've heard from throughout this conference that there is a lot of opportunity to advance research in these areas, but also to better support the infrastructure for studies and their analyses. So I think there's a lot that we can offer across the NIH for that.
Thank you. Yeah. Mr. Fatka.
From a care provider and a researcher, I just, first of all, thank you all for organizing this. Really great to hear from both NIH and also from the community. We share the same frustration that our patients share. When I sit in front of a typical HIV patient, I'm not only thinking about viral load and CD4 cell count, I'm also thinking about diabetes, the blood pressure, the risk for cancer, and it's complicated. And then as a researcher, what we see is that these comorbidities don't occur in isolation. So the same person comes in with diabetes, that same person has hypertension, that same person have other conditions. So they are all, it's not just one thing that you're focusing on. It's a plethora of things that are working together. And when we think about care model, the part of the frustration is that what should be done for this patient, we don't even have a clear understanding of what should be done. A lot of the time, we extrapolate from the general population. For example, if I'm going to give a drug for a condition to somebody with HIV, I not only think about drug-drug interaction, but I also think about drug-disease interaction. So it's really, really, really complex. And then to the question that is asked, how do we, when I as a researcher, one of the challenge of asking for support from the NIH is that, what institute does my grant go to? Yeah, my patient that has cardiovascular disease also have kidney disease. And studying cardiovascular disease in isolation of the kidney disease is not a very cost-effective way when I know that the mechanism of these conditions are interrelated. Yeah. Yeah. And the point I want to make is that we have been very successful in HIV treatment through ACTG, HIV prevention, through HPTN. So we have an integrated research program for addressing treatment, for addressing prevention. I really would want to challenge NIH and other agencies here to look at that model for addressing this issue of aging comorbidities. You know, we need to bring together, the reason why I'm a part of the ACTG, the reason why ACTG is successful is that it brings together investigators, expertise from all walks of life. And I think to address this issue of aging and comorbidity, we need a model that brings not just the basic scientists, the clinical researcher, the translational researcher, social behavioral researcher. We need to create a mechanism that can bring people together similar to what we do with the other network to address this. That would be one of the things that I think will be very helpful. And I think it will be cost effective. It will ultimately save money. It would address the problem and will find a solution to the multiple facets of this problem. Thank you.
Thank you, Dr. Fatka. Yeah, okay, Mr. Roy.
So I just wanted to respond as well to the siloed nature of, you know, for example, substance use treatment, mental health care and physical health care. They're oftentimes very siloed. At SAMHSA, what we do is, so again, one of the things SAMHSA is not funded to do, the agency cannot purchase, for example, HIV treatment medication. However, what SAMHSA requires of our grant recipients to serve this community is to ensure that they have a partnership in place with a provider organization, be it a Ryan White provider or another perhaps provider. Some are actually already funded through other sources to provide this medication or to provide the treatment. So that is a way that we foster partnerships. And I think that SAMHSA grants, when they're at their best, really foster these partnerships within communities for different service providers to be able to meet the needs. It's not as perfect as having everybody under one roof. However, we do really rely on our partnerships within our different communities to be able to provide those services. And for some of our grants, we say it's such an important component of the grant that applicants need to provide proof that they do this work. And if they don't have that proof, they're actually not considered for the grant. So we really have this baked into the way that we provide these services.
Thank you. I think Mr. Johnson has a comment.
Thank you. I would like to add to the need for new models of care and the integration, and whether we're looking at the research effort itself or clinical care, the direct involvement of those of us who are living with HIV. And that involvement has to be routinized. It can't be sort of an add-on or an extra. We need, when we develop new models of care, we have to look at how can we include the routine involvement of people living with HIV and their experiences. Earlier in this conference, the caucus had an institute, and we asked the question, what does quality of life mean for you? And we got an array of answers. And interestingly, we asked it of everybody, and then we asked only the Black women to respond. And there were differences in terms of quality of life and satisfaction. And all of this, I think, has to be incorporated when we think about new models of care. And the research, how does it impact clinical care? The points that Jules made about how inadequate clinical care is, we've seen in the comments, growing body of knowledge, but how is that knowledge affecting clinical care? So I think these are areas we need to discuss more about.
Thank you. Yes, Mr. Philip.
So thank you to the community participants and also to the federal presenters. As I'm sitting here and I'm thinking about this and thinking about what we know and what we potentially don't know, a couple of things have sort of come to mind, both as questions that perhaps this is part of our way forward. One, I'm hearing us talk about a need for new and innovative models of care. But at the same time, I also feel like perhaps what we also need is to understand what is what did I write it down as? What is the medical home model for those aging with HIV? And I think we figured this out years ago about what that should look like for youth. So I can walk into any place and sort of the basic components of youth HIV care are there. And sure, there's some pieces that are added on or it may be different, but there's some basis there for that. And so, but I don't know sitting here if I know what are those components for someone aging. I think we might have some ideas, but I think we probably need to hear from the community what that is, and then we can figure out that piece on sort of a federal level and how do we do that. I think also wrapped up in that, we would be sorely mistaken if we didn't figure out the payment piece for some of that, because that's going to drive implementation and access to whatever that care model looks like, that is a care model, that is a medical home for those that are aging, and what are some of those components. And perhaps there are certain types of specialty care that need to be required as part of that model.
Thank you so much. Online, Mr. Levin has a comment, and I think it'll be a good segue for a question from there as well. Over to you, David.
Well, let's let Jules speak. Jules, you have a comment?
Yes, thank you. So I've been listening very closely to everybody's comments, and let's be clear. I'm here to be honest, truthful, and direct. That's the way all of you know how I am, and why I'm here today. I'm here to present the patient perspective from the real world today. And I've listened to what everybody has said. First of all, many of us who've been working in this aging field for years are very well aware of Compass and Jeannie Ziegler's clinic at Cornell and the other aging clinics. We know about those clinics. So listening to the entire panel here today, the only one, and I also heard the comments from HRSA about the aging clinics. I worked with Laura Cheever in developing those aging clinics 2 years ago. So I'm very well aware of what they are. They're 3 and 5 year programs that could take 7 years to duplicate, that fund 10 clinics for like about 1,000 people. And the entire panel, Ron Johnson is the only one to really confirm what I'm talking about. Everyone seems to not pay attention to what I said. Although Harold Phillips just mentioned it as well. Clinical care today for patients who are older is the problem, not 7 years from now. And that's my question that I would like to hear the panel really address. What will you all do from HRSA and all the very important agencies up there? What will you do to improve care today in the clinic for older people over 65, not in 7 years, and not a bunch of data, and not talk about what we hope in the future, and not talk about, programs that are not really relevant. But so as Harold Phillips just mentioned, he said, what do we want? What do patients want in the clinic today? Well, I discussed that a little bit. I have kidney disease. I have cardiovascular disease. I have 2 fractures and osteoporosis. I have cognitive impairment. When I try to talk to my HIV doctor about it in the 15-minute visit, he can't talk about it. He doesn't have the time or the knowledge, and he avoids it. He doesn't want to talk about it. So we need a care model where that's addressed. And I'd like to ask the panelists to talk about that a little, how we can do this. Thank you.
So great. Thank you, Jules. That's a very important question. I think we'll let some of the panelists virtually respond first, and then we'll kick it back to the room.
If you don't mind, I'll respond for just a moment. Jules, I understand what you're saying. The agency certainly does. The proposals that I was talking about, if they're finalized, could go into action as soon as next year. Things like covering navigator systems, community health, reach out to community health, have community health workers integrated in medication therapy management. So those are things that are being proposed in real time right now and could go into effect in relatively short order. But I think all of us certainly hear and are very sympathetic to the need for more care coordination. The other thing that CMS is doing actually is placing a lot of focus in primary care, and in primary care being the person-centered medical home, and in primary care really doing the coordination of care. And there are a number of models that are actually in place to do that, including a recent CMMI model that is in the process of being launched. So I just want you to know that we hear you, we understand the needs, and I think all of our agencies are trying very hard to make things happen in as near time as we can.
I guess I will respond somewhat because Jules singled out HRSA in that, and appreciate that, and appreciate those comments. There's, I think, a number of different strategies. We do recognize this at the clinical quality level, that there's a need for more cross-training of staff. We need to be, and as I think everyone has experienced, particularly in the past 3 years, that we've seen inordinate stresses on our healthcare workforce. And that is a focus of HRSA and HAB in terms of building up our healthcare workforce, and in particular, making that as well-trained a workforce as possible. So I think that is an area that we're going to focus in terms of how we can get our resources out to our direct recipients who are providing clinical care, and then to our recipients and their sub-recipients. And that's another focus, I think, in working collaboratively with states and cities. I had the privilege of being the director for HIV for Washington, D.C. and the Washington, D.C. area, and that was a major focus of our work. We, with the help of NIH, we established a DC cohort, which is a large cohort study of people with HIV. We've tracked that data in terms of understanding about the conditions, chronic conditions and underlying conditions that are factors for aging among people with HIV, and put that into practice. And I think there are communities across the country that are doing the same, and that's where HRSA can play a supportive role to those recipients in terms of those strategies. It also is, and was mentioned, as Ron said, in terms of participation of community in this planning effort. That is a core feature of the Ryan White program, which is about community involvement in local planning. I was a ex officio member of our planning commission in the DC EMA, and that is developing service categories, descriptions that are sensitive to population needs, and that too is an area that we're going to provide more support to planning councils across the country in terms of their opportunities to update, modernize, and be more reflective of the populations that they're serving. So we know that it's that part of our responsibility is to work in real time, and also to do that in a collaboration with other federal partners and at the community level, with meaningful participation of people with HIV. So while we would like that to have tomorrow, we know that this is going to take a vigorous effort on our parts. Looking at formularies, for instance, in the AIDS Drug Assistance Program that can be able to support many of the different types of chronic conditions that the doctor over here is facing with his patients as a way. And then as Dr. Schreiber was mentioning, and as Ron and I, who go back too long, back to New York City in the 1980s. My goodness, Ron, yes. You haven't aged a day, though. Wherein there was before a Ryan White HIV/AIDS program, but that the opportunity to say that we're talking about people with aging with HIV at a time when everybody we knew was dying, that is an extraordinary transition that we're taking with our population. The points around people being able to become eligible for Medicare, which I will be in a number of years, and a short number of years, the envisioning of how that system of care is provided. And of course, we're also, I think, very sensitive to the notions that were mentioned around as people are aging and are transitioning into different communities, what isolation means, how that affects the well-being well-being of individuals. And that's an effort that HRSA is now under, that HRSA Hab is looking at, is that in addition to all of our metrics and measures, is looking at a framework of quality of life so that we can be promoting well-being, so that people, that it is more than just taking the pill, that their lives are full lives, even as they're aging.
So I want to add a little follow-up question to that. How do we implement this care? And I remember a highlight from our research workshop on Tuesday was Dr. Siegler mentioning that a lot of the care right now is transitioning from infectious diseases towards geriatrics. And Dr. Siegler brought up how there really isn't enough geriatricians in the country anymore. How can we support the training of the workforce in this area?
Thank you, David. What the data I brought up was that in looking at fellowship positions, out of the 411 fellowship positions, fewer than 200 were filled for geriatrics. So many of us are retiring, many more openings for training are there and are not being filled. And so there's this tendency to say, okay, well, as people get older, we'll have geriatricians take care of them, but that's not a realistic expectation of the workforce. And I think that HRSA offers wonderful opportunities for workforce training, and also has an opportunity to find ways to make sure that recipients of funding, for example, geriatric work, the GWEP program, the Geriatric Workforce Enhancement Program, or those who are receiving geriatric academic career awards, include in their mission training the workforce to take care of older people with HIV. That's something HRSA can do, and it takes advantage of all of the resources that HRSA is already gearing toward geriatric workforce training, and just asks its recipients to say, there's a growing need that you need to help with. I don't think one of the points that was brought up during the session on Tuesday was that there are lots of models for where geriatricians can be, but there have to be many, many more models where geriatricians are not there. And so while I think that things can change quickly in some ways, we still don't know the right model of care, and we don't know where we can most effectively use our person power. The other, I guess, point that I would like to encourage CMS and HRSA to think about is that as I listen to this group, there are programs from HRSA, from New York State, from New York City, from ACL, trying to fund opportunities to improve care of people aging with HIV. And my suspicion is that there aren't many people who know of all of them. So there should be some way that everybody knows what everybody else is doing. But one of the problems is we have a grant, and then the grant money runs out. And there's always this line at the bottom, well, how are you going to prove sustainability? And there is no way to sustain these programs unless they are paid for as part of routine health care. So I would love to see CMS and HRSA working together to look at how these kinds of programs and the outcome of these kinds of programs are going to change the way CMS reimburses for care. One of the fascinating things that came out, Kaiser Family Foundation had two reports, one on Medicaid and HIV and one on Medicare and HIV. And Medicaid and Medicare certainly are spending much more on HIV care than Ryan White is. One of the other key points about that report was that only more than a third of people with HIV live in states that that are not expanding Medicaid. And so I would, and the third part that's quite interesting to me is the huge percentage of costs devoted to medication. What I would love to see is one, next year's medications that the president chooses to negotiate prices on be antiretrovirals. I would also like to see that if we could just take $5,000 per person, move it from antiretrovirals to creative care needs, paying for exercise, paying for transportation, and so on. The cost would not change. It would just shift to what is really needed. And the third thing that I would ask CMS to think about, and of course I have no idea if this is even feasible, but back in the early days of Medicare, HCFA made a decision, or Congress made a decision that people with end-stage renal disease would be covered by Medicare. And I would love to see that there are opportunities for people with HIV to be covered with Medicare, so that we address the horrific inequity of states that have not expanded Medicaid and are not providing people what they need and deserve. I'm just going to throw that out. Probably what I've asked for is not even legal, but there's so many wonderful things we could do if we could shift the money around a little bit. And I think there are ways of asking for that kind of change.
Dr. Siegel, I'm told there's some pretty loud applause for your comments there and your suggestions, some creative ideas. I'd like to turn it over to Melissa, who's been elbowing me on the side for a comment.
There are a lot of things I'd like to comment on, but I know we don't have much time. I do want to mention NIA's commitment to developing a workforce that is diverse and that could address various needs across the care continuum for people who are aging with HIV. In particular, I want to give a shout out to our GenStar program. These are grants for early medical and surgical specialists that are transitioning to aging research. And so this is to support early career physician scientists that are trained in either medical or surgical specialties, and early career data scientists that can launch careers as future leaders in aging or geriatric focused research. The topic areas are up to them, and we would really encourage to have research on HIV aging. We also have NIA's BESIN program, and this supports early career investigators who have begun to establish research programs, and this is to demonstrate leadership in the field of aging research. And finally, our resource centers for minority aging research. These are our RICMARs, and this is a program actually that I direct, and this is to mentor promising scientists from diverse backgrounds. And this is especially for individuals from underrepresented groups in the biomedical sciences. And this is to support their training in sustained and impactful behavioral and social science research careers that are focused on aging and health disparities in older adults, as well as Alzheimer's disease related dementias. They have pilot funding. We've supported research on HIV through these programs, and we really would encourage more applicants in these areas. And so thank you for letting me squeeze in a moment. Thank you.
Thank you, Melissa. We'll go back to Geeta for a comment in the room.
Yes, thank you, David. Mr. Johnson, and then Moises, I'll give it to you. Yeah, so we will have a live Q&A after this, after the panel discussion. Thank you.
I'll be quick because I do want to get some of the audience answers. But I think to the training, I would just also add not only the training and the workforce development of geriatricians, but HIV specialists, current HIV and specialists need to be trained in geriatric care and what HIV and aging means. And also to recognize, I think all of us, particularly in the research, that the numbers of older adults living with HIV is growing, has grown, long-term survivors. We're looking at a more nuanced population. I'm in my 70s. My healthcare needs are different probably from someone in their 40s and different from a lifetime survivor who was born with HIV and is in their 20s and 30s. So they've been aging with HIV, but their needs are not someone like me who is, as I said, in my 70s and have been diagnosed before the age of treatment. So all of these nuances, we need more research about what the nuanced population is and how does that translate into clinical care. Again, recognizing that. I think a standard question for the research should be, after conclusions, the conclusions should include how will this impact clinical care and health outcomes for people living with HIV.
And sorry to interject, to add to Mr. Johnson's comment, I think from the research perspective and an NIH, on a short-term perspective, we could also be thinking about how to encourage career development of such investigators, i.e. in geriatrics and HIV, through a variety of training mechanisms and what we call K awards and potential opportunities that could be considered in that area, so that we could really try to strengthen the research activities. And long term, we could be looking at maturation of research projects that we have and beefing up the work that investigators are doing and infrastructure to support centers and networks of excellence. So I firmly believe and agree that that is a need.
Yeah, I have a quick comment, and then I think it would be great to hear, what the community have to say that I have been here. But one thing, just I need to get it out of my chest. We do, it's great to see all these agencies together, all of us having our discussion from our respective mandates and, the work that we're doing on aging, and everybody's doing a great work. What I would like to hear coming out of this meeting is how you're going to continue, how are we going to continue to have this conversation and this needed plan, in which interagencies communications happen in a way that take us to where we want to go. What is the structure? Do we need the White House to organize that? Do we need NIA to organize that? Do we need, but there has to be some sort of structure that allow that conversation to happen.
So I think it's time for audience discussion and Q&A. Sure. Go ahead.
Well, I look at all these agencies, and an agency that really needs to be involved in this whole discussion too is Social Security Administration. I worked at Social Security for 20 years. I retired as a management analyst from San Francisco Region 9. The Program Operations Manual, the DI section, which covers how a person qualifies for disability, does not address aging with HIV. It doesn't address comorbidities. It is still very old in its description of what qualifies. And they always say they go by CDC, but I don't know how that mechanism works to get new guidelines. But I've helped people file for Social Security disability since I've retired who, let's say, are 53, 54 and submitting 300, 400 pages of medical records and getting denied. And it always has to go to, it takes over a year to get an administrative law judge, and then the judges approve it because basically they have the documentation. It's just that when their case goes to the Disability Determination Service of the state, the guidelines are not there. There are no guidelines that say the person's 55 years old and they're having these comorbidities, et cetera, with HIV. I mean, I can read you the DI section of POMS right now. I have it on my phone. It's not there. And even for the CDR, which is continuing disability review process, it's the same. They're not skipped over or blocked. Like there's certain criteria with different disabilities that you can basically remove them from the CDR process. And HIV is not necessarily one unless they meet very specific criteria that was probably back from, when people were having full-blown AIDS right off. So that it might be good to have all these agencies, but Social Security needs to be involved, and there needs to be discussion about how people qualify for disability, because people who are aging with HIV who are in their 50s need the ability to get on disability, which of course 2 years down the road after being on disability gives them Medicare. And that changes a lot of things for people. I mean, I've been through this process with dozens of friends. I know the process from the Social Security side, and I know the process from the outside side.
Yes, I just wanted to say that the cure is in the room. My name is Tiffany Hartman. I live in Roanoke, Virginia. And there are a lot of us Black women that have trauma, and we like to take care of others to help with that trauma. I myself lost my son in 1992 when I was diagnosed. I've been living with HIV for 31 years. I'm a caretaker. One of the first people that helped me was this lady right here, Miss Linda. When I told her my story, and I realized when I seen her here that was awesome. Many of us have degrees. Like I have a bachelor's of psychology degree. I have a master's degree. I have a QMHP. So I think the cure is in the room, and that we can talk about the comorbidities because we're living with HIV of what we have. My husband just got a kidney transplant in December, and it was caused because of his HIV virus. I've had some gynecological issues that are caused from so I think us writing it down, I don't think that we need to wait, like Jules says, next year or 5 years. We need to be writing down what we're experiencing now so it can help other people. So I'm not the type of person to wait on funding from government, although I respect every single one of you. I like to write down what I'm going through, and I like to go to my sisters and my brothers and find out how can we act up. I mean, if we have to, we just have to act up, because I feel like a year from now, because I'm aging quickly, that a year from now, I might be 60 when I'm only 53. So, when you guys say a year from now, I don't have time to be waiting on that. When I had a little boy, I advocated for him, and I didn't have time. He only lived to be 4.5. So I don't have time to wait on people, although I respect every single person in this room. But I feel like utilizing people in communities that have grassroots organizations and not saying no when we need funding. We are the people that are taking your medications and spending millions of dollars. So I just want to say that I'm taking care of my husband, my grandchildren. I don't want to take up the room's time, but I just want to say the cure is in this room. So we have to do something today, not tomorrow. I've lost too many friends and family. Thank you.
So just to moderate this a little bit, please forgive us, y'all. I'm gonna ask the captain to hold the mic, because there's a lot of people want to respond, and I want to ask you to just focus a little bit on the action that you want to respond to. All right, so I'm gonna hold the mic, because if we give some of y'all the mic, we know what happened, right?
Hi, everyone. My name is Nina Martinez. I'm a former public health analyst with the Division of STD Prevention at CDC. I am a transfusion-acquired case from 1983 in San Francisco. I am the country's first living kidney donor under the HIV Organ Policy Equity Act of 2013. How many people in the room knew that people living with HIV could donate their organs to others with HIV? How many in the room have done anything with the HOPE Act since its legalization? Anyone in the panel? Because Secretary Becerra has a recommendation from the Advisory Committee of Blood and Tissue Safety and Availability recommending that these transplants come out of research. But Secretary Becerra has not responded to the committee's recommendation since 2015. The congressional justification for the law said we could get 600 to 1,000 transplants extra per year if we expanded the organ donor pool. After a 7-year period of implementation, we barely topped 400. That is at a cost, because of the 2 NIH-funded multi-center clinical trials, of $24.7 million. I want to know what we're spending that money on, because it sure as heck is not transplant. And I can go down the whole panel. OAR has a website on research advancements in HIV care. My donation from 2019 is not on it, and definitely should be. I asked AIDS United for a public comment. Okay. Okay. But still, the reason people don't know about it, you can't go to organdonor.gov and see a list of HOPE centers. You can see which ones are approved to do it. You can't see who's actively doing it. And the fact that there are 250 transplant centers in the country, but only 30 approved, not actively doing it as a guarantee, means that the legalization of these transplants to produce equity, as is in name, you know, having to travel for it, I went to Baltimore 9 or 10 times. It undoes the equity legalization was supposed to provide. So please, somebody tell Secretary Becerra to make these transplants standard of care. That is something we can all unite behind in the HIV and aging discourse.
I'm going to hold the mic because Ms. Linda told me.
No worries. Thank you all. My name's Nestor. I am a lifetime survivor, which is great to stay in this room because I haven't heard that said from a single person up on this panel today. We're talking about HIV and aging, but not once do we ever talk about people who have been in this fight since the very beginning, since their very birth. In this life I've had living with HIV for 33 years, I've met and lost so many people. We talk about like the ACT UP days and how back was. I have a friend right now in the hospital who was living with HIV since birth as well. And we are never included in research, care. Some of us are used as guinea pigs and have long-term effects from the medications. The AZT was killing full-grown ass people when they were giving those same things to children. And yet we're still here today. The oldest one I know right now is 41, and some of us have not been able to get that long, be alive that long, much less live to see 50 and over. But yet we don't have any kind of resource, funding, care, or even mention in a room and space when we're trying to talk about aging with HIV. So I wanted you all to keep that in your mind when we're talking about that conversation and how everyone has excluded us from these conversations, funding and care, because we need it. I myself stand today after years of hard work and finding it on my own, and I feel there's an exception, but throughout my days, I needed SAMHSA. I had been 13 years ago, you would have found me on the streets and the sidewalk, drunk and passed out, because of all the internalized stigma that comes from living with HIV.
Thank you, thank you, thank you, thank you. We're having a memorial service this evening from a lifetimer who was diagnosed with breast cancer. And because there was no clinical support, and I was the one with her family, her family's here this week, calling the state, the county, the federal, everyone, because they kept saying, we don't know what to do with HIV, with a lifetimer and breast cancer. So again, that reason that we have to come out of solo research, we have to de-silo this space. Go ahead.
Hi, good afternoon. I'm Terry Wilder. Sorry. Hi, I'm Terry Wilder with SAGE. As a former AETC grantee, AETC is sorely, like criminally underfunded. We have to do something around that, and I would suggest we have an HIV and aging specific RFP that they have to respond to. And Robin, I have to bring this up. But first of all, thank you so much for bringing up the data is gonna now for epi data be in 5-year increments. That is going to be huge for us. It's so hard to find information about new diagnoses with the way the data is set up right now. So the last time we spoke was at a FAB meeting. Where are we in removing the upper age limit for the HIV testing guidelines? You had said at that meeting that y'all were in the process of doing I think you said 13,000 academic journal article review. So if you can give an update on that, on removing that upper age limit of 64 on the HIV testing guidelines. Thank you.
Thank you. I'm sure I'll just give an update. So we're still in the rigorous process of going through updating our HIV testing guidelines, but I did want to make it clear that once they are ready, they will be out for public comment. If I had to give an estimate right now, I'd say early next year, they'll be ready for public comment. But I know FAP is also coming in November, so if things change, we'll be able to give an update there.
Just also, we'll take this young lady, this gentleman, they want to go back to the panel for some instruction, whether or not we're taking more community comments or if it's going back here.
Hi, I'm Dr. Renee Hickson. I'm a 28-year primary care provider in mostly Louisiana, New Orleans in particular. And I consider it an honor and a privilege to be in this room today, God-driven, as I've participated in primary care in all of these sectors. And I went back 3 years ago, returned here to DC during the insurrection pandemic to George Washington University to do a geriatrics fellowship because I did recognize the need for this care. However, upon my return to New Orleans, I worked for a Medicare managed program because all the money went there, right? Let's manage all the geriatric people who have Medicare Advantage, but those people who don't have it, sorry, I couldn't do anything for those people. But anyway, I just wanted to, now that I work for healthcare for the homeless, it is biblical perhaps and otherwise, when we care for the least of these. So if our system, it's not broken, it's just not made for us. It wasn't made for minorities. It wasn't made for older persons. It wasn't made for people experiencing homelessness, right? So American healthcare is not made for everyone. Our system's not made for it. So it's not broken. It's just not made for us. So to retrofit all of our needs into a system that's not made for us is going to be difficult. And as a primary care provider, working at the VA for veterans, you just run into obstacle after obstacle of just trying to care for people. So when it's made for someone who's experiencing homelessness, because their Medicaid money doesn't even follow them from Florida to New Orleans. Their Medicare Advantage dollar, it's on and on. It's better really now if they don't have any insurance, because then at least our HRSA funding covers, if you don't have any. Because if you got some, then I got to go through your Medicaid. Oh, this in Louisiana, we have privatized Medicaid, but oops, this drug's not on your Medicaid. You got to be on this other Medicaid that offers, they give you dental, but they don't give you eye care. So again, this comprehensive care for primary care. And perhaps if we just stop letting pharma drive the bus. Pharma's driving the bus for healthcare in America. And if pharma didn't drive the bus, maybe we could get somewhere. Finally, I'll say we have the data. We keep talking about data. Yeah, it's nice to talk data. Data follows money, and money follows data. We already know what it takes, right? We already know. We could ask older persons experiencing HIV what their needs are, and we'd already know it. We can use the data we already have. We also are allowing geriatric programs to close. So it used to be incentivized when I was in medical school. It was incentivized to do rural health track or do a HEC track or do maybe if we incentivize people, students, budding doctors to provide a certain amount of care for people over age 50, then perhaps we would be able to fill that gap. Thank you.
Thank you so much for sharing that. So one more question in the room, and then we have 2 comments online. Thank you.
First of all, thank you for everybody who stood up and spoke up. We appreciate it.
I will try to keep mine brief so more people can. My question would be, with the increase in 50 and above, a 50% increase in this that's going on, I'm pretty sure that many recipient areas have not identified aging as a priority. What can HRSA do through Ryan White or ending the HIV epidemic to require that localized plans include a plan on how to address aging and HIV? Thank you.
Great question. Thank you.
Okay, David, over to you.
Yeah, I just want to read a couple of comments that came into the chat, and I'll add that these are a couple of things coming together. One is from Amy Justice, suggesting that perhaps we should recognize that aging is this multi-morbidity that is a problem across the whole adult age spectrum, and geriatrics is probably not the only answer here. Perhaps we need to stop thinking about one diagnosis at a time. Another thread that came through a couple of other comments, Thomas Villa and Axel van der Peer, is that perhaps there isn't one model that fits all. And there, as we know, healthcare is disparate in different parts of the country, different parts of the territories. And perhaps we need to get creative. And one model might be a virtual direct-to-consumer, direct-to-patient solution where we can break down things and do things more through telehealth. Just as another option here. Again, the comments meaning that there is no one-size-fits-all model that would take care of the diversity of the people living with HIV and aging.
Okay, thank you so much, David, for sharing those, and thank you so much to everyone in the room for sharing your experience and comments and questions. We greatly appreciate that. I would now turn over to Dr. Holtz.
Thank you, Dr. Bonsall. Wow, I mean, what an honor and a privilege, as my primary care colleague said, to be here with all of you and to listen, and you are heard. My name is Timothy Holtz. I'm a primary care provider and a former HIV provider, and I'm the Deputy Director in the Office of AIDS Research. And firstly, on behalf of the NIH OAR, I would like to express our appreciation to the speakers, the panelists, the moderators, and the audience for your valuable contributions to this event and all who attended virtually and in person. I especially would like to thank the NIH HIV and Aging Workshop Planning Group and the NIH OAR staff for their tremendous efforts in organizing this event, many of whom are here in the audience, as well as the scientific workshop held on Tuesday. Both had dozens of participants, which is no small feat to organize, so thank you. I would also like to thank Dr. Richard Hodis, who unfortunately was unable to dial in, and the NIH National Institute on Aging for co-leading and planning these events, as well as Moises Augusto Rosario and NMAC for partnering with OAR to host this panel discussion. I'm grateful to my colleague Harold Phillips for his participation and key overview today and his leadership at the White House Office of National AIDS Policy, particularly in moving work forward on the NHAS indicators. Thank you as well to our distinguished guests for joining us in this important discussion, which builds on previous discussion and efforts of the NIH HIV and Aging Working Group to link NIH and other federal agencies, people with HIV, advocates, and academic researchers. Listening to you and learning from you, as well as our speakers today and the audience, has better informed all of us on the benefits of and the opportunities for partnership of federal agencies, the HIV community, researchers, and healthcare providers to prioritize interdisciplinary research and training and implementation strategies to support people aging with HIV. I also heard that multiple agencies are using the flexibilities they have to conduct implementation and translational research to determine what is working and to publicize it. This includes care models, therapy management, coordination by primary care, and quality improvement in as real-time a fashion as possible. Community and partner engagements inform our research priorities. They ensure we respond to emerging needs, and they're vital to our ongoing progress. This interconnectedness of all of us in this room, and as you said, the answer is here. It's essential to share information, experiences as we have today, and perspectives to shape HIV-related research programs and policies. And to those of you from the communities such as NATAP, Ribbon, NMAC, AIDS United, and others, those names I may have forgotten, we hear you. We are hearing you. Ultimately, we are grateful to be part of USCHA and thank the conference organizers for their collaboration. We intend to build upon this discussion today to guide the work that lies ahead. As previously mentioned, OAR has launched the HIV and Aging Signature Program to catalyze interdisciplinary research and training focused on HIV and aging, leveraging our role in coordinating the NIH HIV research program. In addition, an NIH-wide working group co-led by OAR and the National Institute on Aging is facilitating collaborations for research and training and identifying research gaps and opportunities. We in OAR and partnering U.S. federal agencies you see here today look forward to continuing our work together, engaging in future discussions and forging new and expanded collaborations to improve the health of people affected by HIV across the lifespan. So thank you for attending, and please enjoy the rest of the conference. Thank you.